Okay. Good evening, all. I once again welcome you all for this masterclass series of Delhi Spine Society. And this is the fifth in the line. And we had a humongous success in last four webinars where around 800 to 900 people attending the webinars. So today we have a very exciting topic again. And on behalf of Delhi Spine Society and the president, Dr. Upinder Chahal, who is traveling, I welcome you all again. And we are going to have today a webinar on cervical radiculopathy, which we face day in and day out in our routine practices. We can ask questions at the end because there is a lot of topics which are pertaining to the radiculopathy which you are going to cover. So most probably your questions will be answered in subsequent topics. But even still, if you have some questions, you can type them in the chat box. We will take them up at the end of the webinar. And I request all the faculties to keep up to the time. And if you whenever you have last 1 or 2 minutes left, I will remind you. So let's start with our Rohit Sharma. That is Dr. Archit Goyal. Dr. Archit Goyal is a consultant spine surgeon at Max Dwarka Hospital, and Dr. Archit Goyal was a fellow under us at Indian Spinal Injury Center. So I wish all the best to Dr. Archit Goyal, and let's start with Dr. Archit. He is going to talk on applied anatomy and pathophysiology of cervical radiculopathy. Over to you, Dr. Archit.
Thank you, sir. So I'm Dr. Archit Goyal, and I will be discussing the applied anatomy and pathophysiology of cervical radiculopathy. So the applied anatomy starts. This is a typical cervical vertebra. So the there are 7 cervical vertebra. The C1, C2, and the C7, they are known as the atypical cervical vertebra, whereas the C3 to C6, they are known as the typical cervical vertebra. So this is the anatomy of a typical cervical vertebra with the body, the transverse process having a foramen known as the foramen transversarium for the vertebral artery, the superior articular facet, the inferior articular facet, and the spinous process, and the connecting lamina. Now, this tract is where the cervical nerve root exits the cervical canal to the outside, just posterior to the vertebral artery and between the vertebral body and the facet of the cervical spine. So the components, the important anatomical structures in the cervical spine that has significance on the cervical radiculopathy is the intervertebral disc. So this is, as we all know, that it has an outer annulus fibrosus and inner nucleus pulposus and the two cartilaginous end plates. They are thick anterior and thin posteriorly, which contributes to the cervical lordosis. The disc herniation, disc degeneration, height reduction, osteophyte formation, these are the most common cause of cervical radiculopathy. And as we can see in this picture, so this shows a right-sided C6, C7 disc herniation, which is causing compression over the right nerve root, resulting in cervical radiculopathy. So second important anatomical structure is the facet joints. These are the pillars at the pedicle lamina junction. They are posterior to the exiting nerve root, as we have seen. And these are synovial joints with a capsule. Now, facet joint degeneration and hypertrophy can again result in significant foraminal narrowing and nerve compression. As we can see in this one example of the CT scan, where the facetal hypertrophy has resulted in significant narrowing of the exiting foramen, resulting in compression of the cervical nerve root. Another important anatomical structure is the ancovertebral joints. So these are not synovial joints. They are not true synovial joints. They are formed at the lateral aspect, resulting from the lateral aspect of the lower body, which has a superior projection known as the uncinate process, and the lateral part of the inferior surface of the upper body, which is slightly concave to form this joint, which is seen here, known as the ancovertebral joint. Now, this ancovertebral joint is located just anterior to the intervertebral foramen in the cervical spine, and hypertrophy degeneration of the ancovertebral joint is another, again, important cause of cervical radiculopathy, as it can be seen in this CT scan, where there is degeneration, hypertrophy, and osteophyte formation at the ancovertebral joint level, and that results in cervical radiculopathy. So the most important the location or the most is the intervertebral foramen. This is the gateway of the spinal nerve to the body. The roof is formed by the superior pedicle, the floor by the inferior pedicle. Now, the anterior part is formed by the posterolateral part of the body, the disc, and the ancovertebral joints, and posteriorly, we have the facet joints. Thus, any pathology affecting the body, the disc, or the ancovertebral joint and the facet joint can result in compression of the cervical nerve root, resulting from narrowing of the uh, intervertebral foramen. As we can see here, there are formation of uh, osteophytes at the oncovertebral joint level, resulting in narrowing of the intervertebral foramen. So the intervertebral foramen, it contains the spinal nerve root, but it also contains a very important structure which is known as the dorsal root ganglia, which is very sensitive, and compression of the dorsal root ganglia can result in significant pain, which can be seen in patients with intervertebral foraminal discs. Then segmental spinal artery, the communicating veins, the recurrent meningeal nerve, the transforaminal ligament, and fat, where the nerve root occupies only 25 to 33% of the foraminal space. The cervical nerve roots, so we have seven cervical vertebra numbered C1 to C7, but we have eight cervical nerve roots numbered from C1 to C8. These cervical nerve roots, they pass above the corresponding vertebral body. So as we can see, so the C4 nerve root will pass above the C4 body, the C5 nerve root will pass above the C5 body, and these nerve roots, they have a horizontal trajectory, except the C8 nerve root, which will pass below the C7 vertebra and above the T1 vertebra, and after that the T1 nerve root will pass below the body of the T1 vertebra. Thus, if we have a disc prolapse at any particular level, let's say C5, C6, so it will cause compression of the C6 nerve root, the nerve root corresponding to the lower vertebral body. The spinal canal dimensions, the spinal canal diameter is around 16 to 18 mm. If it is less than 14 mm, it is considered as significant narrowing of the canal, where the spinal cord itself occupies 10 mm in diameter. So what is the difference between radicular pain and radiculopathy? So radicular pain is a pain perceived as arising from activation of the nociceptive afferent fibers in the spinal nerve root. Whereas whenever the radicular pain is associated with motor, sensory, or reflex changes like paresthesias, dysesthesias, and without any evidence of spinal cord dysfunction, that is myelopathy, it is known as radiculopathy, and it results from conduction blockade along the spinal nerve or its roots. So this is the dermatomal distribution of the cervical spine. So this is the C2, which supplies from the vertex to the occiput, the C3, which supplies the occipital area, the C4, which supplies the upper part of the neck and the upper part of the chest, the C5, which supplies the deltoid region, the C6, which supplies up to the thumb, C7, C8, C7 supplying the middle finger, the C8 supplying the ulnar border, and the T1 supplying the medial border of the arm. Similarly, we have the myotomal distribution of these nerves. The C5 is, we can test C5 using the elbow flexors, C6 wrist extensors, C7 the elbow extensors, C8 the finger flexors, and T1 finger abductors. So depending upon the site of compression, depending upon the clinical findings of the dermatome and the myotome, we can identify the nerve root which has been compressed, and depending on the nerve root which is compressed, we can identify the level of the pathology. So the epidemiology, the annual incidence is 1.79 per 1,000 people. It is that common, with the peak in the fourth and the fifth decades. The degenerative changes are more likely to cause these symptoms than disc degeneration, and C5, C6, and C6-7 are the most commonly affected, with C6-7 being the most commonly affected level. It is more commonly seen in males than in females, and it is less frequent than the lumbar spine. Still, the prevalence is 3.5 per 1,000 people. So, what are the causes of cervical radiculopathy? The causes can be disc herniation, it can be disc degeneration, spondylosis, hypertrophy of the facets, oncovertebral joints, the hypertrophy of the oncovertebral joints, the degeneration, spinal instability, tumors, and infections. So the pathophysiology, coming to the pathophysiology of cervical radiculopathy, it can result from static compression, it can result from dynamic compression, and it can result from impaired circulation resulting in ischemic changes. So static compression, these are purely mechanical compression. It could be an osteophyte, as we have seen, at the level of the facet, at the level of the disc, at the level of the incovertebral joint. It could be a disc herniation. It could be a ossified posterior longitudinal ligament, ossified ligamentum flavum. So static model where there is pure mechanical compression of the spinal cord. So similarly, this is one of the specimen models that shows a disc causing compression and a osteophyte at the level of the foramen causing compression of the exiting nerve root. Now that the dynamic model, so we can have neck flexion. Neck flexion causes lengthening of the posterior wall more than the lengthening of the anterior wall with reduction in the AP diameter, which results in stretching of the cord and the other neural structures like the nerve over the anterior structures. Similarly, neck extension will resulting in pinching of the neural structure against the ligamentum flavum. We have lateral neck movement, which causes uh, compression of the intervertebral foramen. Now, this forms the basis for Sperling's test, where whenever there is lateral flexion of the neck, it causes further narrowing of the intervertebral foramen and can result in provocation of the symptoms, such similar to the resulting in provocation of the symptoms of cervical radiculopathy. Another mechanism is the pincer mechanism, where there are pinching forces in extension, where the neural structures get compressed between the upper vertebral body and the lower spinous process, can result in compromise, microcirculation, ischemia, edema. Another is impaired circulation within the cord. So we see that the nerve roots, we have the posterior radicular artery, the anterior radicular artery, and the segmental arteries. These are critical medullary feeders which can get compressed, resulting in ischemic changes. There is impaired venous drainage, and these changes can result in neuroischemic radiculopathy and myelopathy. Another very important cause in patients with acute disc herniation is inflammation, where there is nerve irritation from the herniated disc. The nucleus pulposus herniation causes activation of the inflammatory pathway. There is inflammatory cytokines, interleukin 1, interleukin 6, substance P, bradykinin, TNF alpha, and prostaglandins that result in chemical neuritis, resulting in inflammation and hence cervical radicular pain. So this is another a diagram showing the disc herniation causes compression, as well as a MRI image showing a disc herniation causing narrowing of the intervertebral foramen. Now, depending upon the pathology, the patient can have symptoms of neck pain, patients can have symptom of radiculopathy, and patient can have symptoms of myelopathy. Thank you.
That's a wonderful presentation, Dr. Archit. Uh, so we'll move to the next topic, that is from Dr. Sudhir Ganesan. Dr. Sudhir Ganesan is a professor and a consultant spine surgeon at Sri Ramchandra Medical College, Chennai, and he will be talking on clinical evaluation of cervical radiculopathy. Actually, how to evaluate your patients in your clinical practice. Over to you, Dr. Sudhir. You are muted. Yeah.
Hope I'm audible now.
Yeah, yeah,
Thanks,
yeah.
Dr. Gururaj. And so once again, thanks for the Delhi Spine Society, Dr. Rupinder Chahal and Dr. Gururaj for giving me this opportunity to be present here today. So Dr. Archit actually nicely covered the entire pathoanatomy, pathophysiology, everything, so that it will be easy for you now to follow up with the clinical evaluation of cervical radiculopathy. And myself, I'm Dr. Sudhir from Chennai. And the difference, as he said, radiculopathy and radiculitis. So radiculopathy means whenever there is pressure in the nerve, and radiculitis means inflammation of the nerve root. And there will be severe pain because of the inflammatory mediators present. Here, there is a schematic diagram showing the disc coming out and pressing the nerve, and the patient will be having pain throughout the upper limb, as you can see here. So now, why we have to concentrate more? Obviously, for each and every patient who is coming to our clinic, we have to concentrate in clinical examination. But here in cervical pathologies, the challenge is that there is a high degree of clinical overlap in these patients, and it can usually mimic other musculoskeletal disorders, neurologic or cardiac pathologies, because they mimic symptoms almost similar to them. And often radiographic compression can occur at multiple roots, and you want to know what is the exact source of pain. And the least reason, but however it is important, is the lack of sensitivity of physical examination on determining the particular level which is pathognomonic. So to start with history, whenever a patient comes to you in the clinic, they typically complain of neck pain or decreased range of motion of the neck and severe radiating pain along the upper limb. So when you are asking or eliciting the history, you have to clearly ask for the duration of the pain, and yeah, like in any other history, you have to ask for onset, progression, duration, the type of pain, and is it associated with any numbness or paresthesias of the fingers of the upper limbs. And the next most important history that you have to ask is the aggravating and relieving factors, whether it is aggravated by bending down the neck or whether it is aggravated by prolonged work. And the rest of the history, like in any other history, you have to ask for early morning stiffness, finger joint pain, and other things. But when it comes specifically to cervical pathology, you have to ask for a few more history, which is very, very important, which is pertaining to the shoulder joint and to cardiac causes. You have to ask occasionally radiating to the upper limb, but you have to ask this history. That is very, very important. And nowadays, in most of our clinics, we do triage, we look for BP pulse before they come to us. So that has to be done as a routine. The next one is the shoulder pathology. You have to ask whether the pain is more prominent over the deltoid aspect of the shoulder region, because any shoulder pathology patient will not typically say that the pain is in the shoulder joint. They will show point out in the regimental batch area or the deltoid region, and you have to ask whether the pain is worse in the night, especially when they turn towards the particular side. Because usually frozen shoulder or periarthritis shoulder patients or deltoid condition, they will have this classical history of pain in this aspect, and the pain will be worse in the night, and the pain will be more when they turn towards that side. And in history, you have to ask for history of diabetes mellitus, the duration and the treatment. And then you go ahead with the physical examination and other provocative tests and the diagnostic workup. That is radiation, will come and the arm pain
Sudhir, we lost you. Sudhir, we lost you. Sudhir. Okay, people, can you hear me? Archit, can you hear me?
Yes, sir, you are audible,
Yes,
sir.
sir, you're audible.
We have lost Sudhir, right?
Yes, sir. Sudhir sir is not.
Okay. So then maybe we, when she comes back, uh, so we can take the next topic. So Sanjay Rajan, has he joined? He is saying he is about to join. I'll just call him. हाँ, आपने ज्वाइन कर लिया? आपका ही टर्न है. हम्म. हम्म. Okay. So meanwhile, if we have any questions, we can take it up. Mhm. Oh, okay. Dr. Dubey, can you answer this question? What are the most important differentials for cervical myelopathy in India? Dr. Sudeep?
Yeah, can you hear me now? Sorry, I don't know, it got
Okay,
disconnected.
you're back.
Sorry about this.
Okay,
Yeah,
okay.
I'm back.
Continue.
I'll just continue. Sorry about that.
Yeah.
And so this is the diagram which Dr. Arshit was also showing. So the referred pain for cervical facet joint. So the pain may radiate to the occiput region or to the back of the head as well as to the occiput and to the head. Another common kind of patients will come to you. On examination wise, you have to look for axial tenderness, paraspinal spasm, and the range of motion. So paraspinal spasm will be usually present in case of acute cervical disc prolapse. When there is an acute event, the patient will have severe paraspinal spasm and there will be loss of cervical lordosis. And the range of motion, this is the normal range of motion. And in case of acute events, again, the range of motion will be restricted, and in case of any cervical myelopathy or cervical pathologies as well, the range of motion will be restricted, especially the extension and rotations will be restricted in these patients. So neurological examination, Dr. Ashit has covered, and this is just in nutshell. C5, C6. C6 is responsible for wrist extension, C7 for wrist flexion, and C as triceps extension, C8 is for finger flexion, and P1 is for finger abduction. Now, coming to the special tests. So these are the tests that you have to actually do in these patients to rule out or to be very clear about the cervical radiculopathy or radiculitis. So you have the upper limb tension tests, or it is otherwise called as the brachial plexus tension test. The second one is the Bakodi sign, which is commonly called like that, or the shoulder abduction test. The next one is Sperling's test, and the final one is the distraction test. So this one is quite a complex test, which is the upper limb tension sign. It has four tests, and as you can see, this is a it stretches the cervical nerve roots, and it is specific for each and every nerve. Each position is specific for each nerve. For example, the test 2 is specific for median, 3 is for radial, and 4 is for ulnar. It is used also for brachial plexus. But however, we do not use this test very commonly or routinely in our clinical practice. But it is better to know what this test is. The next common test which we routinely do is the Sperling's test, wherein you stand behind the patient and give axial pressure when you ask the patient to extend and rotate the neck towards the side of the pathology or the pain. And because of the compression of the foramen, the patient will have the same pain which he or she was experiencing before. The next one is the Bakodi sign. The patient will classically present to you with the abducted shoulder with the hand over the hip, because it will widen or it will increase the space for the nerve, and the patient will be very, very comfortable by this position, and this is called as the Bakodi sign. The next one is cervical distraction test. Again, we do not do it very routinely in our clinical practice because it is quite a dangerous test. If the patient has some amount of neurological deficit, it can actually worsen the neurological deficit in these patients, and we have to be extremely careful. So what is the sensitivity and specificity? According to this paper, the Sperling's test has a sensitivity of about 50%, whereas the specificity, it actually goes up to 93% in the patients. So the commonly performed tests are the Sperling's and the Bakodi's test in the clinical scenario. And the Bakodi's saying the patient himself will come to you if the pain is very severe. And according to this particular article, a positive Sperling's test as well as positive findings for neck distraction, though we do not do it, and the Wenceslas manual may be suggestive of a cervical radiculopathy, while a negative ULTP may be used to rule it out because of its high sensitivity. The next one is the upper motor neuron signs, or otherwise called as the myelopathic hand signs. So you have to look for the Hoffman sign, finger escape sign, Lhermitte sign, and inverted radial reflex and the Babinski sign. So this is an example of a patient. You can see the classical Hoffman sign whenever there is severe cord compression with myelomalacia and cervical myelopathy features. You can clearly see by catching hold of the middle phalanx of the middle finger and you give the stroke, you will be able to see flexion of the index and the thumb. The next one is the other upper neuron signs, which you have the finger escape sign. And this is a classical finger escape sign. This is a full-blown myelopathic feature in the patient with cervical myelopathy. You can see shoulders flexed and wrist pronated and forearm pronated and the wrist in extension position. The same patient, if you see here, you can see the scapulohumeral reflex, which is very, very classical. Though I just wanted to show you the scapulohumeral reflex, which is seen in myelopathy. If you tap along the spine of the scapula, you can see shoulder abduction, and that is another pathognomonic feature of cervical myelopathy. So you can clearly see this shoulder abduction because of contraction. The next one is the extensor plantar, which is seen in patients with cervical myelopathy. It is another classical UMN feature. So all these things you have to do as a routine in your clinical practice when you are looking or suspecting any cervical pathology, because to rule out any myelopathic signs, because that will dictate your management and treatment. You can clearly see the dorsiflexion of the great toe and fanning of the other toes. And this is ankle clonus, which you can see very clearly in these patients. Again, a classical pathognomonic sign, UMN sign for cervical myelopathy. So finally, you have to rule out your shoulder, elbow, and wrist pathology. And I think the next speaker will talk in detail about this differentials and the masquerades of cervical radiculopathy, starting from impingement syndrome, Prof, shoulder pathology, suprascapular nerve impingement, even tennis elbow, carpal tunnel syndrome. Everything can mimic cervical spine pathology, so you have to rule out. Finally, at any cost, you have to rule out chest pain, chest pathology, or cardiac source, because that is going to be a life-threatening one. So whenever a patient gives history of breathlessness, palpitation, and has these red flag signs, immediately do not hesitate to get ECG and get a cardiologist opinion, because as orthopedic surgeons, we are very poor at reading ECGs. ECGs, do not take it for granted that it is not a non-cardiac chest pain. There have been various instances that patient will present to you with vague upper limb pain and vomiting through episodes. It could be an inferior one. And cervical dizziness have been reported in cervical spondylitis in about 10 to 12% of the patient. It could be various reasons, predominant of which is the proprioceptive reason. And again, when you are suspecting vertigo or dizziness in these patients, you get an ENT opinion, rule out BPPV, and then you take cervical spondylosis into consideration. Finally, X-rays. The other speakers will be discussing about X-rays, MRI to rule out the cervical spine pathology, disc, and other things. And finally, electrodiagnostic EMG and NCS, when everything is not fitting in one. As we usually say, spine pathology is like mathematics, 2 plus 2, it has to be 4. And there is no 3 in this or 1 in this. So everything has to fit in. If it is not fitting in, just get electrodiagnostics and neurologist opinion. So this is a clinical case example of a left-sided disc prolapse, and this was done for the patient. The patient had all tests, special tests positive.
So there, can we wind up?
Yeah, wind up.
We're running short of time. Yeah.
So this is the patient with cervical pathology, but he was posted for surgery elsewhere, and you can see clearly it's a drop-arm sign test positive, and the patient had doctor. So history and clinical examination is very important. Neurological examination is mandatory. Always you have to rule out shoulder, elbow, and cardiac pathologies. Thank you, and sorry for the technical glitch in between.
Okay. Thank you, Sudhir, for that nice presentation. We have next speaker, Dr. Sanjay Rajan. He is head of neurosciences at Artemis Hospital, Delhi, Gurgaon, and he's going to talk on masquerades of cervical radiculopathy. This topic comes in this webinar because we all know that first thing, as a surgeon, as a doctor, the principle is to do no harm. For that, we have to have a proper diagnosis. Otherwise, we'll end up operating or treating a patient which is not really a cervical radiculopathy as cervical radiculopathy. So over to you, Dr. Sanjay Rajan. Dr. Rajan?
Am I audible?
Yeah, you're audible.
Okay,
You
let
can
me share
share
my
your screen. Yeah. Yeah, you can make it full screen. Yeah.
Yeah. Very
Yes.
good evening, everyone.
Yes.
So we'll be today talking about those tricky situations where we often assume that the patient has cervical radiculopathy, but the root cause turns out to be not the root. It means we're talking about masqueraders which mimic radicular pain, but do not actually involve the cervical root directly. And this is especially relevant for all surgeons, as Dr. Guru said, that because missed masqueraders can lead to failed surgeries, it can lead to prolonged rehab, and often lost trust of doctor. So we have to see how we can form a practical pattern recognition system, in which we are looking for masqueraders as a reflex, not as an afterthought. So let's begin by looking at first the basic symptoms that a typical cervical radiculopathy presents with. So you have a typical dermatomal pain pattern, and this is what we are looking for. This is what we're trained for. A textbook cervical radiculopathy with a shooting pain, either electric or usually unilateral, and you'll find that the patient may have some paresthesias or weakness, but even if it's just a person who's telling you about a shoulder pain, if you dig deeper, you will find that the patient either has some neck stiffness or the swelling is positive. So these all point towards the original of the pain which to be the nerve. And these can, of course, ultimately be confirmed with MRI and things like that. So after having a look at the basic radiculopathy, that typical classic picture, so let us look at the how the mimics behave. Now the challenge arises when one of these elements is missing. Either the dermatomal pattern is not there, or the associated the presence of neck pain is not there. So in these cases, you will find that they either the basic pattern will be very different. They will defy logic in the sense that they will not be dermatomal in nature, and you will not have any neck movement related pain. And territories, sometimes multiple territories can be involved, or sometimes distal nerve territories can be involved, and we'll discuss all of these possibilities one by one. And also, more importantly, that you will have a patient who will be either not responding to spine-directed treatments, the typical, medicines that you give or treatment that you give for cervical radiculopathy, the patient does not respond. Either the patient can have a normal MRI, or he may have an MRI which looks bad, but somehow things are not matching, because symptoms either they fluctuate or they migrate. And in some patients, symptoms may even remain static. And we look at this subset of patients also, in which the symptoms actually remain quite static, and they've been around for months and years, and we still don't know what the reason is. So let's start with the first and the most common masqueraders, which are the peripheral nerve entrapments. Now, these are probably the most frequently seen in the OPD, and we do tend to get swayed, when we see somebody who's complaining of hand pain, numbness, or weakness, and then we jump to the conclusion that this patient may be having a C6, C7 radiculopathy, and the MRI also shows some suspicious compression of the nerve root in the foramen, and then we start looking at that direction. But we have to be more diligent and find out whether the symptoms are completely distal, in the sense that the numbness is only in the thumb or index finger. Then we are probably looking at a carpal tunnel syndrome, right? And this will mimic C6, C7 sort of a dermatomal pattern. And secondly, if you're looking at a patient who's got ring and little fingers involved, we will think in terms of C7, CAD1, but it could be ulnar nerve compression. So what do you look for? In a carpal tunnel syndrome, typically the symptoms are going to become worse at night or after the patient, says that I've been tied too long. And ladies will say after, they're working in the kitchen. And whereas in the patients who have got ulnar nerve involvement, you have a typical tunnel sign, or you have a weak hand grip. Similarly, there's a subset of patients, very rare though, the way the radial nerve, one branch of radial nerve gets involved, posterior interosseous nerve gets involved. It can mimic a C7 nerve root palsy. We have a patient whose wrist has a wrist drop. Now, these patients will have a wrist drop without sensory involvement. So that's the clue. that why is this patient having this stop without sensory involvement. So the key here, as you can make out, is the distribution and the provocation. So provocation in a median nerve is different from ulnar nerve versus radial nerve, and whereas distribution is also very different. So you have to be extremely important to keep these in your DD, especially when the symptoms are more distal and they are patchy and not completely involving the entire dermatome. Let's go to the next most common pathology that we find, shoulder pathologies. Very, very commonly mistaken by, I would say, neurosurgeons, because we don't deal with so many shoulder pathologies, and extremely important for our neurosurgery colleagues to understand. Now, these patients will typically have painful, movements, either it's active painfulness or passive. So you're able to passively move, the patient will have pain, and a different subset of diseases will present with different kind of symptoms. So, for example, if the patient has got a pain around the deltoid, we might immediately think of C5. But patient will also be telling you that there's some sort of a impingement kind of feeling, in the sense that he can't lie on one side, or he can't reach behind his back. So these are kind of cases where you look at shoulder as the possible cause. You could have a weakness of abduction in a rotator cuff tear with night pains, or overhead pain with the subacromial impingement, or you could have a global stiffness in a patient who's got stiff shoulder. But this stiffness actually comes pretty much at the later stage. And so in the early stages, you could be confusing frozen, you will not immediately think about frozen shoulder. So extremely important to assess the joint thoroughly. If the pain is mechanically linked, in these cases, you have to think in terms of shoulder, right? So let's go to the next possible masquerader. So this is again a relatively less common, but often confusing. We'll have patients coming to you again and again, and if you don't think of them, you don't consider them. In these cases, as we've studied, especially people who've done a bit of this in their general surgery courses, so there is compression of either the brachial plexus or the subclavian nerves. Now, it's not very common, but you will have a patient who's got diffuse upper limb symptoms. They're not very dermatomal. There will be heaviness, fatigue, or paresthesias. But the clue is positional worsening. So this is extremely important. That patient, either by elevating the arm or overhead activity, or they will tell you, that I feel heaviness after I'm holding a steering wheel, or I can't hang the clothes overhead, or find difficulty in probably sometimes painfulness in handling my hair and things like that. So this positional aggravation is one of the very important keys for thoracic outlet syndrome. It is often neurological, but sometimes it could be vascular also. So that's something that will add to the clue in terms of the patient feeling either bluish viscous, or there is some cold feeling of that. So there are tests that are being done, but they're obviously Adsons and Wrights, but they're not very specific. So we don't really depend on them completely. MRI can give us an idea, but often it is normal, because you are not finding anything. Sorry, you're not finding anything there. So posture is, as I said, the most important thing, and in general, it will require a detailed study of the MRI of the thoracic outlet area for us to be able to detect it properly. Let's go to the next most common. This is also more common than we think, in the sense that patient will often come to you with either sudden pain, was suggestive of idiopathic brachial plexus neuritis, where you find sometimes the MRI is totally normal, or you can be misled by a degenerative MRI. The key here is that the pain and the pattern and the weakness is also non-dermatomal. And usually it will be sudden pain, and the weakness will follow a little later. Now, in these cases, this particular pattern of symptom development is important. And EMG is not usually advised in the very early stages, despite patient having weakness, because it will not show any changes in the first 1 to 2 weeks. So sudden severe burning pain, which wakes the patient up at night, think about this. This is Parsonage-Turner syndrome. And often it happens in multiple nerve roots. That's why it's non-dermatable in nature. So In terms of traumatic plexopathy, this is pretty obvious. We know that there's a fracture or there's been some sort of involvement of brachial plexus, but non-traumatic patients, it becomes more difficult to detect. So I think that should be quite clear. The next set of patients, which we often don't think about, and we do find that our pain colleagues are more accustomed, or you can say trained to look for, are the myofascial pain syndromes. Now, in these cases, this is the typical patient I was telling you about, the non-progressive pains. So they respond to local therapy by in terms of stretching or dry needling or injections. The way to detect them is to actually see, do a palpation. We find that there's either some sort of a pain gets aggravated on compression. Again, they will not be having a non-dermatomal, they will not be having a dermatomal pattern, they will not be having neurological symptoms at all. But you could have pain referred to any part of the upper part of the body, even right down to the forearm, because of the way they behave. And patients will typically tell you, that they're either stressed mentally, or because of the poor posture, they're having this kind of pain. And in general, usually becomes worse by the end of the day, things like that. But it doesn't progress over weeks and months in the typical pattern that you will see in radicular pains. So this is extremely important. If your local treatment is helping you, then it's typical myofascial pain syndrome. Okay, so this is, I think, the last category where we're talking about even a more rare subset of diagnosis, which can cause symptoms which mimic radiculopathy. So when it lies outside the neuromuscular skeletal system, this is where you look at cardiac ischemia. It will often alarm the patient thinking that it's a cardiac pain, and that could also be true. And we may sometimes mistake it as a radicular pain. So extremely important because of for specialty. So in this, it's important that it's a dull pain. There's no radicular picture, and you should think about this in patients who are middle-aged, especially diabetic, and really it can happen even in younger subset of patients. Apical lung tumors, pancreas tumors. I've yet to see one, but it's something that we come across a lot in our theoretical discussions, that patients would have a apical lung tumor, which causes radicular pain, either shoulder or arm pain, and you can have associated Horner syndrome. So this is relatively rare. And of course, gallbladder diaphragmatic irritation kind of patients, something we can keep in our DD, though it's relatively rare for us to come across such patients without any symptoms associated with the gastric system. So this is something where those are few features, associated symptoms that can guide us. So then if you have all these patients, these kind of categories where the nerve root is not involved, then how do you proceed? What is the diagnostic strategy? So it's important to start with the most important thing is a pattern recognition. So if it is dermatomal or not. If it is dermatomal, you're still safe for it as radicular pain. But if it's not dermatomal, that should be your first red flag, where you feel that you start looking at other aspects. Fine. So if it's dermatomal, but only partly dermatomal, then we're looking at distal peripheral nerve neuropathy. Whereas if it's non-dermatomal, then we're looking at all other kinds of pathologies. Then you look at the neck. Is the neck contributing to the pain? So swelling causes pain, distraction causing pain. Is the range of movement okay? Is that causing pain? If all those are there, then we can still assume that this could be contributing. So even though person may be having cervical spondylosis without radiculopathy, but we can say that yes, this is something that we should think. When it's one case where we should start thinking in terms of a radicular pain. Shoulder movements, elbow movements, wrist movements, and of course, peripheral nerve testing. Extremely important to be more thorough in these so that you make sure you're not dealing with any of these masqueraders like shoulder or peripheral nerve involvement. Systemic screening is something we often don't do in a busy OPD, but in general, a few questions that you can ask is whether a patient has night pain or history of trauma or weight loss. So these will point out towards a pancreas tumor or night pains, shoulder pain, or history of trauma causing brachial plexus sort of injury. So this is also extremely important for people to differentiate. If it's an acute onset, and it's followed by weakness, it's a brachial plexus neuritis. Whereas if it's chronic kind of pain, that's myofascial, as I said before, something which doesn't fluctuate much. And if it is fluctuating, then it's usually thoracic outlet symptoms, positional, right? So this is a few things which help you a lot: timing, provocative factors, and the pattern of pain. So this is something that you can use as a checklist for us to guide. So in general, if once you have that suspicion, then is when you have to direct your investigations accordingly. So for example, MRI spine should only be done if the symptoms suggest root involvement. I know it's easier said than done, but sometimes the MRI spine can further mislead us into thinking that it's a radicular pain, and it's usually in the beginning it was not. So if the patient has non-dermatomal pain and there's a multiple nerve involvement, one to think in terms of brachial plexus involvement and get a brachial plexus MRI, or if there's a movement-related pain of the shoulder, then get MRI of the shoulder done. And EMG NCD should be done only after about 2 weeks of onset of pain. Otherwise, you will not get the right report. Diagnostic nerve blocks and peripheral nerve entrapments, very useful, especially when you have a sort of a double syndrome, compression syndrome with cervical radiculopathy also, confusing the picture. So it then helps us to, you can say, prognosticate the treatment that we are giving. Blood tests rarely helpful in general, but one can do all these things as a matter of routine. So let the symptoms lead the scan and not the other way now. So how do you avoid mistaking musculator for a red root pain? One, not all radiating arm pain is cervical origin. Look for red flags, whether it's non-dermatomal, non-mechanical and patchy. Examine shoulder, test for entrapments of the nerves, and palpate the myofascial points. So use EMG wisely, timing matters, and match symptoms to source and not just the MRI findings. Thank you so much. Asha, this is just a small recap. So if you're ever in doubt, look for these clues. If the pain is postural or positional, think of thoracic outlet, as I have already discussed. If it's night pain with full passive ROM, think of rotator cuff. If there's pain which is vague, muscular, and triggerable, myofascial. And when there is sudden pain followed by weakness, then that's obviously brachial neuritis. Thank you so much. Hello.
Oh,
Hello.
hi. I was just unmuting. Thank you,
Oh, that's
thank you,
okay.
Dr. Rajan. That was a wonderful presentation. I think you are traveling, and thanks for taking out your time for this. And now we saw the applied anatomy, and then we saw clinical evaluation, and then how to exactly not to miss radiculopathy and how to differentiate between other differential diagnosis. Uh, so then next we will see, once you have diagnosed, how do you decide what is to be done? So for that, we have none other than Dr. Sudhir Dubey. He is a director, spine services at Medanta Hospital, Gurgaon. Over to you, Dr. Sudhir. Sir, I think you are muted, Dr. Sudhir Dubey.
And the screen needs to be made full size.
So
Yeah.
once you have a diagnosis of radiculopathy, it is easy because you have to just decompress the root which is going outside. If it's a myelopathy, you have to decompress the cord also. But in certain cases, radiculopathy, you might have to decompress the cord. So there are various instances when you have to
Dr.
do
Dubey,
this.
can we make it full screen?
Yeah, I will make it full screen.
Yeah. Yeah.
So
Thank you.
we have to decide whether it's a global surgery at that disc level or it's a focal surgery at that disc level. The decision will be based on whether the disc is confined to foramen, whether there is a canal which is compromised, like if you have a borderline canal stenosis, and if you just address the foramen, then you're not doing a thing looking into the future. So you have to have a different strategy. When you have adjacent 11 threatening discs, so if you are doing a C4-5 and you have a C5-6 disc also there, and which sometimes can be on the opposite side, and sometimes the radiculopathy may be because of smaller disc and the other disc might be bigger. So that also will change your strategy. And in the end, if you're doing a procedure just to decompress the foramen, or you have to do a global procedure where you have to address whole of the disc, will depend on whether the disc height is adequate or not. And also there is a focal or global kyphosis, which will determine whether you have to put a spacer in between the disc, and that will that is how you deal with the strategy. Now, focal procedures are foraminotomies. They are done both anteriorly or posteriorly. Global procedures for the disc levels are ACDF, disc replacement, cervical corpectomy, and posterior laminoforaminotomies with or without fixations. So these will be addressing basically all your radiculopathies. Foraminotomies are preferable when the disease is just in the foramen. And global procedures, ACDF, disc replacement, cervical corpectomy, or posterior laminoforaminotomies will depend when there are levels which are involved more, or when whole of the canal is getting compromised. Difference between ACDF and disc replacement: you will use ACDF in trauma settings. You will also use it for older patients. Younger patients with good disc movements, you will opt for disc replacement. Corpectomy you will address when there is stenosis, relative stenosis of spinal canal, and there are two levels of disc which are causing radiculopathy. Posterior laminoforaminotomies are done in cases where ligament becomes more of a compromise factor rather than the small disc which are there. So in that you can go posteriorly, and this you can do with or without fixation. Anterior approach is always better because what you find is the nerve root, when it exits the spinal cord, it will drape over the disc and then go outside in the front side. So anterior portion of the root is basically the disc, and anteriorly, if you approach it, the anterior pathology is addressed more completely and well. Solid fusions can be achieved because the bone is to bone fusion is the most optimum fusion. 85% of load bearing in young people will be there from the anterior part. Disadvantage of anterior is if you are going to do more than 3 levels, your motion, if compared to a procedure where you're just doing a foraminotomy, the motion is lost. Congenital severe stenosis you cannot address and anteriorly, and severe deformity also, if it is there, you cannot address with the anterior approach. Posteriorly is less, but it is not a laminectomy is not a good choice for a radiculopathy. But you can do a laminoforaminotomy. I will show some case in which you can use that. And the decompression is away from the offending element. But in all the cases when you do a laminectomy, which is very adequate, you will see that the cord has come out behind. So it's come dorsally, and the ventral pressure is that's why mitigated. Disadvantage again, if you're not doing with fixation, kyphosis, epidural fibrosis is there, cord kinks. I've seen patients with posterior laminectomy who present with later on with myelopathy and persistent neck pain. Laminoplasty is in between procedure, which is not for radiculopathy at all. So ACDF and disc replacement you will use for patients where there are multiple levels and you have a kind of a kyphosis which is there, and you can address it. You can, this patient, if you try to do a foraminotomies, you will find that you're also landing in trouble few years down the line, and you will have problems because there are multiple levels. You are seeing cord getting kinked. So foraminotomies are not ideal, and ACDF will be an ideal procedure for these kinds of patients. And cervical laminoforaminotomies are very good for these kind of patients. They are presented with posterior ligament which is bulging out with small disc, and you can see on flexion and extension it becomes different. So a procedure where you go from the sides and just decompress with a small incision will also help with you. It's not a technical video, so I'm not playing the videos, just showing you for this thing. You can also, if there is a subluxation at one level, you can also put a lateral mass screws at that place. Anterior cervical discectomy, because of anterior pressure, you have a compromise. Now, this kind of a procedure you can do with the foraminotomy, the discectomy, or you can do a ACDF from there. So, foraminotomy, you can take out this disc fragment, though it is causing a canal compromise. But if you go from the side, this amount of the disc can be removed. So, this is a procedure in which we did a foraminotomy and could get away with this. And this is the foraminotomy thing, and then you can do the ventral decompression of the, you can see the thecal sac, and this is around 6 mm hole into the part of the vertebral body where you go from the sides, and you can address this. You can also do an oblique corpectomy in this, which is functionally preserving. But you have to remember that the global compromise, if it is there, it has to be addressed with these kind of a procedures. And then posterior foraminotomy procedures are also followed. And this is what you have to do. So from my thinking, it is you have to differentiate between focal and global, and any procedure which you are comfortable with, do that. Anterior procedures are much better than a posterior procedure, and you should address the pathology, and at the same setting, if there are adjacent level problems, try to incorporate in your decision making that thing also. Thank you for your attention.
Thank you, Dr. Sudhir.
Yeah.
So we'll take questions at the later. And now we have seen basically the anatomy, diagnosis, and the choice of surgery. Now we'll go for real thing, that what we do practically in our OTs. And Dr. Sachin Bodkar, who is the professor at neurosurgery department at All India Institute of Medical Sciences, will show us the video of a ACDF. Over to Dr. Sachin.
Yeah, my screen is visible, Dr. Gururaj.
It's visible. Go ahead, Sachin.
Yeah.
Yeah, I can.
So, thanks for the invitation. And Dr. Sudhir has correctly said that the anterior pathologies are better addressed by the anterior cervical discectomy and fusion. Usually, up to 2 levels, people do ACDF, even 3 levels also. But multisegmental disease with a preserved lordosis is usually addressed posteriorly. But up to 2 levels or a kyphotic spine, the ACDF is a better option. So I'll just quickly recap the important points of ACDF procedure. This is the position. As you can see, the patient is in neutral position with Gardner-Well tongue applied for distraction. When you put the interbody graft or cage, you need some amount of distraction. You can either do it with a Gardner-Well tongue, or you can use the vertebral pin distraction system also. But we frequently use this Gardner-Well tongue with around 3 to 4 kg of weight. We have to strap the shoulder so that in case of short neck, or if you're operating at C6, C7 level, you can clearly visualize the disc space. At times it becomes difficult, especially it's a short neck. The C-arm is positioned in the lateral view as shown, and it can be slided down as needed. The other thing which is important is fixing the tube. The tube is usually fixed on the left side because for most of the right-handed surgeon, right-sided approach is easier. So the tube has to be fixed away from your side of exposure. So that will help you, and it won't come into view. So the next step we all know is the incision. There are some anatomical landmarks, but the most important you can check on C-arm, and then planus skin crease transverse incision, which is more cosmetic. The approach is Smith-Robinson approach, and we have to carefully identify the plane between the carotid sheath and the laterally and the tracheoesophagus medially, and putting the self-returning retractors or a handheld retractor, then discectomy, decompression, a careful vertebral end-plate preparation, decompressing the PLL because it is one of the most important structures which needs decompression, and then putting either an autologous bone graft or a peak cage, and then instrumentation. Each step, it may look very simple, but each step is fraught with danger. So a proper plane identification is the key, and every step we have to be careful so that we have an uneventful outcome. Usually, we have to work medial to the sternomastoid and between the midline. So the incision need not go beyond midline, and it should not also go beyond the medial border of sternomastoid, because we have to work in the anterior triangle of the neck. And usually, transverse incision are preferred, and vertical incision are usually avoided for cosmesis. And that was what I was referring to, finding this plane between the carotid sheath laterally and the tracheoesophagus medially to reach on the body between the two longus colli muscle is the most important thing. So, this is the two longus colli and the prevertebral fascia in between, and we have to reach here and do a decompression between two uncinate process, a discectomy or a corpectomy, whatever you decide. The next, I will like to play a video. Is it visible?
Visible. Go ahead.
Yeah.
It's visible. Yeah.
So it's a two-level discectomy, C4, 5, C5, C6, a transverse skin crease incision, and we have inside the skin and the subcutaneous tissue, there will be a thin layer of platysma muscle below this, which has to be separated. And the important thing is to make this subplatysmal plane so that you can reach easily in the prevertebral space, because we are operating at two levels here. So subplatysmal dissection is important. The next step is to identify this plane medial to the carotid sheath and between the tracheoesophagus. Once we do it, we put the self-returning retractor, usually blunt-ended. There are sharp-ended also, but we have to use the blunt-ended one. You can see the two longus colli and the vertebral body in between. You can confirm the level at this point and define the intervertebral disc. At times, there can be bridging anterior osteophytes which obscures your disc, so they may be gently drilled so that you get better access to the disc space. The next step is to remove the disc. The initial part is removed with the bigger biopsy forceps. Then you may have to use curette to remove the other part of the disc. You can appreciate this curette, and the disc which is attached to the end plate has to be removed. And the movement of this semicircular movement of the curette is important. It should not go towards the cord. At times, there can be bleeding after decompression because of epidural venous plexus which was being compressed. You can pack it with a small gel foam and then go at the next level. Again, this is the other level of this, the lower level. Initial part with the disc knife. The exposure is from the uncinate process to the uncinate process. Again, using the curate. Then using this vertebral body distractor to open the disc space and remove the posterior part of the disc as well as the PLL. At times, you may need to drill the osteophyte as well if they are causing compression. Once you can clearly see the dura at both levels, and then you decide to put the peak cages with pre-filled bone graft. At that time, that our Gardner well tongue, which was applied, is gently pulled to achieve distraction. You can you put a 2-level peak cages and then apply an anterior cervical plate. The screw direction should be convergent in the axial plane and divergent in the sagittal plane to have more pull-out strength. Using a plate is an optional thing, but since it was a bit of a kyphotic spine, we thought to supplement it with a plate to recreate the lordosis. And then you can close it, the platysma muscle, and then put a subcuticular suture. And at times, the scar is quite invisible. This is a small 4-centimeter incision skin crease, and it's not cosmetically very good. So this is another video of showing the plane, how to identify. We usually use this peanut sort of instrument, which we call peanut. It's basically a cotton blob on a artery forceps. And you can see we are working medial to the carotid sheet and over the vertebral body. We are checking the level by bending the needle so that it doesn't pierce the dura. That is a way in which you can check the levels. Just another video. You can see the carotid pulsation in this video. And then you reach there. So I just concentrate on the first 10 seconds. So that's the carotid sheath and the carotid pulsation. We are medial to that. And the retractor is protecting the esophagus medially. And once it is all defined, we go below and apply the self-retaining retractor. The disc space is quite collapsed here. So this is a corpectomy video. So we are doing a 2-level discectomy above and below. The disc space is quite collapsed. And then removing the disc. And once we get some space, then we will remove the body in between. So this body is quite small, and this is now moving after both the discs are removed. And I usually harvest bone graft from this body, which rather than drilling it entirely, so that this bone graft can be used to be put in the cage. And once we do this, then we decompress the same way, remove the body, both the disc, the PLL, and then put an interbody. Interbody cage, basically a mesh cage, like put in this case. I'm just hurrying. So the mesh cage, the sizer, and then put the bone graft which you harvested, and over that put a plate. So So to conclude, the importance of having the proper planes cannot be overemphasized. So usually transverse skin incision, work medial to the sternomastoid, palpate the carotid with your fingers and work medial to that. And that plane is usually always avascular and it will take you to the anterior part of the vertebral body. Use handheld retractor initially on both sides, and once you confirm that you are at the right place, then after some subperiosteal elevation of the longus colli, you can then put the self-retaining retractor, and that should also be non-traumatic sort of retractor, which doesn't have sharp blades. That will help the carotid sheath as well as the esophagus. And then you can work on the intended disc space. Remove the disc initially, remove the cartilaginous end plate. If there are osteophyte, you may have to drill with maybe a cutting drill. And always divide PLL, start from lateral side, in which it is a bit thin, and then go medially. And usually that will give you better decompression. And that's it.
Thank
Use
you. Thank you.
autologous bone graft, or if you do not want to use autologous bone graft, you can use peak cage as well.
Thank you, Dr. Sachin. Now I invite our guest faculty, Dr. Ayush Sharma, who is the head of the department orthopedics and spine at Western Railway Hospital, Mumbai. And I would especially thank Dr. Ayush. Today is daughter's birthday, and he has to rush back to her cake cutting ceremony. But still, he is here to honor his commitment. And we wish from Delhi Spine Society, wish her happy birthday and a blessed year ahead. Over to you, Dr. Ayush. Dr. Ayush is going to show us a video on cervical forearm anatomy.
Thank you, Guru. It's always an honor and pleasure. And thanks to all the good friends in Delhi Spine Society. So without wasting any time, as you know, let's jump into the video. So I will show you two videos. This is a tubular forearm anatomy. So doctor, if you look at it, as Dr. Sudhir Dubey already told, it has to be, a lateral radiculopathy, and that is where you do. So this was a hard disc. So basically, you do either mostly for a radiculopathy, you can do only a forearm anatomy, which was done in this case, or a forearm anatomy with discectomy, which I'll show you in the other case. So basically, it's a tubular forearm anatomy. You can see this is a 16 mm tube, cranial caudal sides are marked. There's always some muscle which creeps in. So you remove the muscle, and then, you need to identify the junction between the facet and the lamina, and that is where you need to drill, because you need to. So this, you can see, this is the landmark which you need to drill. And the reason being, you need to decompress the root, which is just out there. At the same time, you don't want to, unstabilize the spine. What Dr. Dubey already told you. Normally we use a high-speed burr and you go about it. Sometime it could have some amount of bleeding. Once you have gone through the initial bone, you can use a 1 mm ronger to complete the forearm anatomy. What you will see is just above the root, there is a sheath of plexus. Sometime it can lead to a very torrential bleeding. So you have to have patience. It's all about patience at the end of the day when you are a spine surgeon. All you need to ensure is that you have made a complete good decompression of the root, and that is the end point of your forearm anatomy. If you want, you can go up to the dura, see the edge of the root above and below, and you can complete the thing. So this is how it goes. Now I'm using a 1 mm ronger and I'm trying to complete what I have to do. This was a case of, and before you finish, as you can see, I'm using a ballpoint point probe to ensure that I have, done enough bony decompression. And then you do your ensure, and we have put a hemostatic matrix here. But if you don't have, it doesn't matter. It normally stops with the patients. And then you ensure a good decompression. And then in this case, we have also done a post-operative. So this is the root, as you can see at the end of it. And in this case, we have done a post-operative CT also, just to show you how much bone is removed and it is exactly what you want to do. And this is just a 2 centimeter incision, as you can see. So this is important. This is a post-op X-ray, and even the post-op CT will come. What is important is you have to do accurate targeted work, and that is it. So let's look at the other one, which is a endoscopic foraminotomy. The steps remain the same. The principle remains the same. This is a case where you can see there is a C6-7 disc and it has migrated, gone down, and it was causing the weakness of C8 weakness. And you can see why. The disc is just underneath the pedicle. And this, again, like any MIS approach, you have to be targeted, you have to be precise. But the beauty why we chose endoscopy here, because endoscopy has a 30-degree angle. It really allows you to see down. And I will show you how you can go from C6-7 and even remove a disc which has gone below the C7 pedicle. So again, the basic steps remain the same. What I showed you in the previous video, again, you use, instead of a burr, you use a endoscopic burr. You do exactly the same amount of bone cutting, which you do in what you did with the tubes, or you do open. The basic principles of spine surgery, no matter what type of surgery you are doing, is exactly the same. It is just the axis which changes. That axis sometimes give you a certain advantage, and that is where it is. So exactly what we did in the previous case is being done here. Instead of using the regular burr and the Carrison, what I'm using is a endoscopic burr and punches. And this is the C7 pedicle superior part. Because the disc has gone below the C7 pedicle and is lying down, I wanted to drill a bit of it to get a better access. C7 is normally a huge pedicle, even if you drill. So it is just less than 1/3 of it was drilled, because that angle which the disc has gone down, you really needed to get it there, so that to ensure that you get the disc out. So this is, and then once we remove it, you can see this is the neural structure, which you can see here. So now it is all about identifying those neural structure going out there. So what we have is these are radio frequency probes. They're also your eyes and your fingers. So it allows you to safely dissect few things. So we have identified the lateral margin of the cord. And this, you can see, this is the lateral margin of cord. This is where the pedicle, and this is where we should ideally get the disc. So you try to retract a little bit just to get it. So you can see the cord is up, and this is your extruded disc. So just below the cord. And then the beauty of endoscope is that it really has a beautiful vision, and that is what. And this is the first fragment, as you can see. So you can just trying to take out the first part of the extruded disc, and this is how it comes. So we have taken out the first fragment. But one problem you have to understand is, because your vision is limited by a small axis, make sure that you remove everything. Don't leave anything behind, and that is important. So go search for another fragment, and you can see there's another fragment which is simply popping out. So this is your second fragment in this case. And then once we got a third fragment, which is which was still there, and this is the third fragment. And as we go ahead, we go down and look at another fragment which is coming from just below the pedicle, and this is the inferior migrated fourth fragment. Look where you can reach, and that is the beauty of endoscope. That you can really, because of the angle which you get, because of the 30-degree degree vision, you can even go so down and remove some of the fragment, which are very, very difficult if you are thinking to do this any other way around. And this is the fourth fragment, and this was the inferiorly migrated fragment, which was the main culprit in this case. And then you go and remove it, and that's it. And that is the end of your foraminotomy and the end of the discectomy. And all this is done with, and you ensure a decompression if you need to. If you look at it, we have even decompressed the lateral border. And if you don't want to do more, you can go ahead and do more. But in this case, this was enough. And I think I have a post-operative. So these are the 4 fragments which was removed. And we also have a post-op MRI. And this is again the same thing. The window of the decompression remains the same. And this is the post-operative MRI. You can see all those 3-4 fragments, and the big disc sitting out there has been removed. And this is post-op day 1, and that is the beauty of this case. And one thing I just want to show you, and this is why I love endoscopy. What you are looking at is a vertebral artery. There was an aberrant vertebral artery just below the root, but it really gives you such a good vision. Sachin was showing a vertebral artery. I can also show you, but that was carotid artery. I'm showing a vertebral artery just below the C6 root, and this was an aberrant vertebral artery. But the vision is so good that even if there is aberration or the anomaly, you can really, really look at it, and it makes your life safer. And before I end, I hope you guys are joining us next month in MISAB and BSS and ASMES be combined. And if you want to know more about MIS endoscopy, please do join us, and we will like to welcome all of you. Thank you. Thank you so much.
Thank you, Ayush. I think I will allow you to go. I think your kids are waiting.
Yeah, I'm already
Thanks for
getting
that.
my calls,
Yeah. Thanks for
Thank
that.
you so
And
much.
we'll take up questions now.
Thank
And we have a lot of questions in the chat box. Dr. Sachin, if you're around, there's a question from Amritsar. Dr. Prabjot Singh is asking, is there any need of fixation in the cervical spondylolisthesis in grade 1 and grade 2? Sachin, if it's not around, Dr. Sudhir?
If you have a listhesis, you have to fix, and it has to be fixed if it is listhetic. Otherwise, you will have a progression, and just doing a foraminal compromise, the other side foramen will get compromised over a time. So unilateral approaches, focal approaches are not good for that. So if you have a listhesis, do a fixation. Or at least if a grade 1 listhesis and a young patient, you can do a disc replacement also, non-traumatic in nature. Any other question? You are muted. Guru Raj, you are muted.
Sorry. Okay, Dr. Sudhir Ganesan. So the question is from Dhaka, Bangladesh, and the question is, what are the difference between radiculopathy and myelopathy? Clinically, how do you differentiate? Sudhir?
Yes, sir. I'm here. Can you hear me now?
Yeah, I can hear you.
So clinically, see, there are two things now in history-wise. As I said, history-wise, you can clearly differentiate radiculopathy from myelopathy, because radiculopathy, the patient will have a dermatomal distribution of symptoms, and the patient usually will have associated significant neck pain, and the radiculopathy will be usually associated with one particular dermatome, and you can ask the patient to draw a hand diagram. They will clearly show that. Even if they have numbness, they will clearly show in the fingers. Whereas in myelopathy, it can present like anything, and it will be a vague symptom, and most of them usually in the initial stages will come to you with complaints of gait unsteadiness, loss of manual dexterity. There is another concept called as radiculomyelopathy. When there is involvement of the root as well as the cord, they will have mixture of both. So in other words, in cord involvement, you will have clumsiness, paresthesias, numbness, gait instability, difficulty in buttoning shirts, difficulty in mixing food, handling instruments, change in handwriting. All these things you have to ask clearly to the patient. So those are all the early clinical features and symptoms of myelopathy. Whereas in radiculopathy, they will have classical pain radiated along a single dermatome with numbness associated with that particular dermatome and weakness of the corresponding myotome.
Okay, can you just, Sudhir, can you
Yes,
just
sir.
take up the next question also?
Yeah.
How do you differentiate myelopathy from motor neuron disease?
Yes, see, myelopathy will have a combination of
motor as well as sensory symptoms. Whereas motor neuron disease, they will not have the classical paresthesias, numbness, or clumsiness. It will predominantly present with a proximal or a classical pattern of progression from distal to proximal or proximal to distal, and they will not come with a gradually progressive kind of thing. It will be more of a subacute and insidious onset of thing, and sensory symptoms will be very relatively very less in case of a motor neuron disease. It will be more of a muscle weakness, and the patient will come with loss of balance and muscle weakness, and extrapyramidal signs also will be there if a gross group of motor neurons are involved. So, and in myelopathy, they will usually have a spastic gait, and spastic symptoms will be predominant, whereas in motor neuron disease, that will not be predominant. So all these features will suggest some kind of motor neuron component, and in that case, you have to refer to a neurologist to get a second opinion. And then, very rarely, some motor neuron patients may have features of early myelopathic changes, so you must not be carried away with that. And we all know that NCV and EMG will not give you a very good idea about the pathology, but you have to refer to a neurologist to rule out motor neuron disease.
Great. Great, Sudhir. That was great answer. Dr. Dubey, and this question is from, I'm surprised, I can see you are a doctor from my hometown, Dharwad. And Dr. Sriram is asking, what is the effect of chronic cervical radiculopathy and hand dexterity function?
See, the hand dexterity will be typically in the distribution of C7T1 distribution. So hand dexterity won't be affected because this are rare, it will be less affected. But if you have a myelopathy which is there associated with it, the hand dexterity will come into this features. So as such, hand dexterity won't get affected, the hands as such. But in the case where you have a shoulder or elbow weakness because of radiculopathy, then you can have mild amount of dexterity involvement with that. And the previous questions in UK, there was a large study where they studied the cervical myelopathy and they got operated. 10 to 14% patients over years turned out to be motor neuron disease. So always know 1 in 10 patient what you're going to operate is going to be motor neuron.
Okay, great.
Okay.
Okay, thank you. Dr. Archit, there's a question for you from Behrampur. Why cervical spondylitis is mostly associated with headache and vertigo?
So there are multiple reasons to the association with headaches. It could be because of the dermatomes. As we have seen that the upper dermatome, the C2, the C3, and the C4, they also have supplying the posterior part of the scalp, the occipital region, and the upper part of the neck. And second, it could be because of the muscular myofascial reasons involving the trapezius muscle that can cause vertigo and headaches.
Dr.
Dr.
Sudhir?
Gururaj,
Yeah,
if I may add to that. See, this is a totally different concept of cervical vertigo. So there are we have heard of these Ruffini corpuscles and Pacinian corpuscles. It may sound a bit different now because it's such a molecular level. So those receptors are present at the cervical facet joints. Okay, and whenever there is any abnormal activation of these proprioreceptors, especially the Pacinian and Ruffini corpuscles, which is in the facet joint, okay, that will abnormally get stimulated, and they have a direct connection with the inner ear, and that is one of the commonly and widely studied area, and that can result in cervical vertigo.
Okay.
So whenever you are thinking of cervical vertigo, we usually say no, it is because of onco-osteophyte complex which is pressing on the vertebral artery that can result in dizziness. That is not so. Even mild cervical spondylosis with facetal involvement can result in that. In those cases, you can try facetal blocks or proper facet unlocking mechanism or strengthening exercises for the neck to unload the facets.
Okay, so you mean vertebral artery compression is not the reason at all?
No. It is one of the reasons, but
one
it is
of
a
the
very,
reasons.
but it is quite rare compared to the other common reasons. It is one of the reason.
Okay. Dr. Dubey, do you have any comment on this? Because it's very common scenario we see in day in and day out in our clinical practice. Cervical vertigo and headache because of spondylitis. Dr. Dubey?
Repeat the question again. There was some phone call.
So
Tell me.
basically, there's a question. What is the cause for cervical spondylitis causing vertigo and headaches?
So it's a idiosyncratic thing that cervical spondylitis is causing vertigo and all this. But the thing is, whenever you have a vertigo, you have benign positional vertigo, and your posture of the cervical spine is very bad, you will aggravate your this thing vertigo. So as such, it's a misnomer. Some people treat it as an entity, clinical entity. Some people don't. So this is what it is. So better take care of the posture of the patient, restore the lordosis, and correct the scoliosis. That will make the vertiginous things better. And neck pain is normally which if you have a C3-4 facet involvement, you will have behind the ear pain. If you have C2-3, C5-6, that pain will go in the occipital region and it will go till the vertex of the head.
Okay.
So that is because of cervicogenic pain of the head which is there. But as such, it's a misnomer. It's not a definite association which is there.
Oh, great. Actually, Dr. Sudhir Ganeshan came up with some basically theory for the Refinis
So there are a lot
corpus.
of theories. It's a misnomer. I've been seeing this, and this theory has been there. But in the end, I found that if you have a benign positional vertigo, have the Appley's maneuver and treat the vertigo. That is better for the patient and treat like that. And if it is still going on, then better correct the posture, and that also helps the patient. So in my practice, I will just do that.
Okay, great. So that uh, ends our webinar for today. It's 9:30 sharp. And I would like to thank all the faculty from Delhi Spine Society. And as the convener and education chair of Delhi Spine Society, I would like to thank Sun Pharma for giving the tech support. Arvind, Rajesh Agarwal, Mr. Pawan, Dr. Sudhakar, and his team. And I also heartily thank all the participants. We had participants from Nepal, Bangladesh, and from far corners of India in this webinar. And then the next webinar is going to be the hot topic these days, that is endoscopy. So the webinar is going to be on full endoscopy next webinar, that is on the second Wednesday of next month. So I welcome you all for that next webinar. The program will be out soon and you will all get to hear this. So thank you one and all, and good night.
Thank you, sir.
Thank you. Thank you. Arvind, we can stop recording and we can